ladies and gentlemen, and welcome to the Nobody Asked Me Guy show. Guys, listen, I'm your host, Melvin Casey Lars, and this evening we have a very hot topic. As you guys know, we don't waste your time with cookie cutter things and drab conversations. We have with us Dr. Jean-Claude Cadet. Dr. Cadet and I will be discussing health disparities in the United States. Are they real or imagined? Now, let's talk a little bit about Dr. Jean-Claude Cadet. Now, Dr. Jean-Claude Cadet attended Columbia University College of Physicians and Surgeons, from which he obtained his MD in 1979. He did residency training in psychiatry at the Department of Psychiatry at Columbia University and in neurology at the Department of Neurology at Mount Sinai Medical Center, both in New York City. He came to NIDA, RIP in 1992, where he is presently a senior NIH investigator and the chief of the Molecular Neuropsychiatry Research Branch. Dr. Cadet has co-authored more than 300 papers, abstracts, and book chapters on the mechanisms of addiction and brain damage. He has also written papers about some cognitive dysfunctions observed in cocaine and marijuana abusers. Presently, his laboratory is studying how stimulants and oxycodone can cause changes in the expression of genes and proteins in the brain. He is also investigating the epigenetic basis of methamphetamines and oxycodone addiction by using animal models of drug self-administration. Now, the Cadet lab has shown that unexpected foot shocks can separate rats that were already taking a lot of methamphetamines into addicted and non-addicted rats. Dr. Cadet found differences in the expression of ion, which is potassium, channels in the brain of those animals. The lab has also found that rats that took a lot of oxycodone can also be separated into addicted and non-addicted rats by foot shock punishment, I should say. These findings are similar to those observed in the humans. Dr. Cadet is using these models to try to develop better treatment for humans who abuse psychostimulants and or opioid drugs. So guys, as you can see, we have with us an extraordinaire, a man that does research, a man that can tell you things from knowledge and not from a political base. So ladies and gentlemen, sit back, relax, and as we introduce you to Dr. Jean-Claude Cadet. Dr. Cadet, good evening, sir.
Good evening. Thank you very much for inviting me to have this conversation with you. I'm very glad to be here and shoot away. Let's have a real conversation.
Yes, sir. Let's be sure to do that. And you know, we just start this thing right off, Dr. Cadet. I'd like to just jump right in and get things rolling. And you and I were talking off camera about many of the disparities and things that we're faced with. And true to our topic, you know, we're talking about health disparities in the United States. Are they real or imagined? Now, as a physician and as a person that does research and you work a lot with the mind, how would that relate, if it does, to disparities, or if there are, or in your professional opinion, are there disparities when it comes to health, our health, as it relates to our less melanated brothers and our heavily melanated brothers?
That's correct. I think that the evidence is very profound that there are differences in terms of the prevalence and the incidence of some diseases, not all diseases, but there are specific ones like hypertension, diabetes, HIV, obesity, stroke, and some immune and infectious diseases are much more common in African American or Black Americans. And those differences, though, are not genetic. And you know, when you read some papers, old papers written by white scientists, they would really discuss in their discussion part of their paper what are the genes that are doing this. But it's not the genes, right? For example, hypertension, the percentage of African American, Black Americans with hypertension is actually higher. But then when you start looking at other aspects, diet, racism, a place where people live, you start identifying other causes of these disparities. Now, in addition to the prevalence of hypertension being higher in our Black brothers and sisters, the treatment that they get from mostly white physician is different, okay? So I can tell you, because of the shortage of African American physicians, most of us end up seeing white American physicians. So the treatment, and you follow over the course of treatment, the lack of resources and not having insurance, for example, people might delay going to doctors, and then they end up with complications such as stroke. Now, the same thing can be said about diabetes, okay, where the prevalence it is higher in the African American population, but stress can induce diabetic responses, okay? And then so when you start calculating, oh, where do people live? What is the diet? People living in food desert. So they end up with diabetes that has nothing to do with genes, which a lot of people try to say at the beginning when they were writing these papers, oh, there's a gene for that in this American population. We have to find it in order to cure people from diabetes, but not even thinking in terms of, okay, what are the racist, how does racism in fact influence the expression of diabetes in Black patients, okay? Obesity is another one. So you can actually predict who's going to develop obesity by age 2, 3, because 50 to 60% of kids who have bad diet when they're small end up with obesity. In the United States, actually this one is both Black and white population. In general, in the United States, more than 30% of the population suffers from obesity. But if you look at a map of the United States, in states where there's a high proportion of African American citizens, the prevalence is higher than 35%. So we do have these issues, but when we go to doctors to take care of them, they don't provide the necessary care that we need. So the reality to this disparity, the one actually that kills a lot of us is chronic kidney problems.
Chronic kidney problems.
Kidney problem that people don't pay attention to, because you develop chronic kidney problems because you had diabetes, you had hypertension, and the repeated insult by high sugar level and high blood pressure level really leads your kidney to fail. Over time, by the time we end up seeing doctors, because of a lot of reasons, our kidneys are failing. And sometimes people have to get on dialysis, or they have to get kidney transplantation. And then the other problem with that is that Black patients are really down the line. If you're looking at a line of people waiting to vote or waiting to get transplant, the Black people are in the back of the line, just like we used to be on the back of the buses. So it's really very troubling that we suffer from this disparity. But I think it's very important for your audience to realize it has nothing to genes, it has a lot to do with the racist structure of this country, and in science and in medicine, so that we have this impact on our health. That really needs to be fixed by fixing structural racism.
Absolutely. You know, which brings us right into my next question. It's been so much talk because all of us are concerned about this COVID-19. And can you share with us, we've all heard on the news, I mean, with those of us being lay people and not being physicians or professionals, about how COVID-19 is especially affecting communities of people of color and that kind of thing. Is there a direct relationship with getting this airborne disease due to some of the disparities that you've mentioned?
That's a really excellent question. So a lot of people are talking about COVID-19 as if that's the cause of the disparities, but it's not, right? So the combination of a very infectious virus plus the disparities that I mentioned before, it's a really bad combination. And I have some slides I would like to share with your audience, if I may.
Please.
So let's see if I can show them. Okay. So can you see the slides?
Not yet.
Can you see them now? I'm trying to share the screen, but besides that, but I can read some of the slides in terms of the numbers.
I just shared my screen. I'm sharing my screen to see if the slides will come up.
Okay. But one of the, I can show you, there's a map talking about where COVID-19 is.
Okay.
So what the map shows is that the vast majority of the places where you have a lot of COVID-19 are in places where there are a lot of African Americans, right? But the issue there, though, is people talk about complication. But when you look at, even in Louisiana, for example, the Ochsner Health Center, so the vast majority of the patients at that clinic, let's say 70%, actually white Americans, okay? But if you look at, they wrote a paper about, they published a paper on 3,600 patients who were diagnosed with COVID. And what they found is that 70% of the patients who had COVID were Black Americans, okay? So you're starting out with only 30% of the patients are African American, but when you look at COVID diagnosis, you have 70%. The other thing that the authors did that was really good, they look at other diseases that these patients presented with. Guess what? They had hypertension, they had diabetes, they had kidney failure, and they also have HIV, okay? HIV is one that they don't talk about a lot, but HIV is really a very significant risk factor for increased mortality with COVID-19. So they also look at who ended up in a hospital. So those were patients who come in their clinic, and then they say, okay, who are the people who end up hospitalized? 76% of the people who ended up being hospitalized for COVID-19 were African American. And then you look down the list and say, okay, what other diseases these people had? Hypertension, diabetes, chronic kidney problems. And then they look at the ones who died. Same issue, okay? But when you're doing statistics, you can take out certain things in the statistics. So when you control for hypertension, kidney failure, diabetes, it's no longer African American dying. So the gene part of it again shows up. It's not really a genetic factor. It's the fact that this Black American were suffering from disparity that preceded, okay, the diagnosis of COVID-19. So having this disease makes it easier for you to get the infection and makes your clinical presentation in terms of severity are much higher if you have these diseases, and the mortality, right? So the morbidity is higher and the mortality is also higher if you have these other diseases. Not the fact that you are Black, not the fact that you're African American, it's the disparities that make us more vulnerable, okay? The other thing about this, I don't know whether I watched the news as far as when the stuff was going on in New York City. Who are the people who were essential? People like us. If there was a video of a train in a New York subway system of people after they closed down New York, but the train was running, the train was full of Black men and women because they were essential. At the time, they were not wearing masks. So who end up getting sick? Our essential brothers and sisters ended up in hospital and ended up dying from the COVID-19. So it's really, you cannot escape the fact that the racism, the racist decision, the structural racism that existed in the United States make it much more likely that African Americans were going to end up with COVID-19 and also dying from COVID-19. So you could say, somebody could say, well, this is just Louisiana. But there are papers from New Jersey, there are papers from Detroit, there are papers from New York, all come to the same conclusion. Black Americans with hypertension, diabetes, and chronic kidney problems tend to have more likely to have COVID and to die from it.
Wow, and wow, I would love to be able to say I'm surprised, but I'm not. I didn't have that information professionally and from the research. But as you can tell, I'm at a loss for words. But everybody tries to play politics with everything, especially now with the election coming up and that kind of thing. Do you feel that the current administration can do more to assist the people in getting more accurate information as it relates to their overall health and wellness?
I think we all can do more. I mean, I think one of the things that as a professional I try to do, I try to write on LinkedIn, I try to interact with people who should go and seek medical help. I think also though what we're facing, because I don't think we can depend on this administration to be very helpful in terms of COVID because of their stance about the disease. I think instead of playing macho with a virus that's infectious, that can kill people and killing us a lot, really killing Black people, we need to take some responsibility to make sure that people who go to our churches, our young people wear masks and wash their hands and not listen to propagandas that have nothing to do with health. I mean, we have some physicians, even though we don't have enough. Right now, as you know, we represent about 13–14% of the general American population, but only 5% of the physicians are Black physicians. So it's a really low number. And the medical school are not doing enough to increase the number to a point where we can say we have enough Black physicians to work in those communities where we are needed. Now, the number is only 5%. People like me, for example, who work in a medical institution where we do research, the number goes down to about 2.7%. So we have a total of 5% Black physicians. And we need more doctors doing research and more doctors also seeing Black patients. And the medical school are not very happy in terms of helping people like you and me get into medical school. I mean, we went through that. I think it's really, really important to have Black physicians. In the 70s, when I was going to medical school, there was this big brouhaha among all the medical school. Yes, we're going to increase the numbers, we increase the numbers. And then this is now 2019 and 2020. The numbers have not budged. So, you know, you find yourself at my age thinking, with all of the hoopla now about, yes, we recognize racism in science, recognize racism in medicine, that is just really smoke and mirrors dance. I mean, so I hate to sound like this, but that's my feeling about it. But obviously, we could do more politically, but it's not going to happen unless we take responsibility as Black men and women to actually take care of each other instead of depending on politicians to do it, because they're not going to do it.
Absolutely. Now, as you share that with it, it's our responsibility, and well, it is. You know, initially and even throughout this COVID situation, there was talk early on about it doesn't affect children and all that kind of foolishness. When you hear disingenuous information, misinformation like that, how do you combat that kind of information?
It's very tough to do. I mean, what I've done on LinkedIn, when people have groups that I read the papers, I look at who the people are who wrote the papers, and I say, okay, and I look at the numbers. I pay a lot of attention to that. And then I say, okay, I can share these papers with other folks, okay? Now I cannot go to my barber, but what I've done in the past is share information when you sit there and we're talking back and forth with other bosses, you can share information and you can try to get them to go treat their hypertension, their diabetes, so that they don't develop stroke and stuff like that. But right now, we're not in the situation where we can actually engage people directly. So what I've done is basically put out good papers, what I think are good papers, on LinkedIn, on other places, on Facebook, for example, so that people can read them and say, okay, wow, kids actually can get this disease. And then even when the manifestations of the disorder is not as really terrible like you see in some adult, the kids who are infected, they go home, okay? And in our cases, in some African-American communities, multiple generations live in the same house. So the kids go home to a mother and father, and their grandmother or grandfather, who's older than we are, like in their 70s, might actually get infected with this COVID-19. And then suddenly they're losing their grandparents who were taking care of them because the two parents were working in essential jobs, okay? So when people are saying why it's okay to send kids to school, I get very upset about that. I actually go on Twitter and say, wow, keep your kids at home. And lucky for me, a lot of the people I know, they're all keeping their kids home. And you know, it's really putting our kids in danger. It's like we could lose the older generation of people with hypertension or diabetes, and then suddenly we have these children, no parents, no grandparents, because their parents have high blood pressure, diabetes, or kidney problems. But now, because of age, the story of age is true, okay? So they're above 65, they're above 70, and then they get infected and they die, and the parents also get infected. Now everybody in the household is infected. And I can tell you personal history, something like that happened recently with my family in New York, where my sister's husband got infected. He didn't know it. He came home, infected the other people in the household. So the kids won't know that they're sick because they might not have very severe symptoms. They might have a little sneeze, okay, and then they go home. But then their parents are infected. Especially the grandparents are infected and they can die.
Wow, that's powerful. You and I were talking off air, and we were talking about our parallels. And unfortunately, it happened to my niece. My niece's husband came home. He had gotten infected, and he infected the children. And they decided, before they knew they were infected, they visited the other niece and her family, and their granddaughter and the husband got infected. And thank God they all survived. But I hear you very, very clearly. It can be very devastating and very frightening.
It is frightening. So I tell people all the time when I talk to them, when I write email to people, wear your mask, stay away from your neighbors, don't visit with anyone you haven't been in the same household with since March. I mean, and wash your hands all the time. So I've developed this obsessive compulsive disorder where I wash, even though I didn't go outside, I'm washing my hands all the time. It's not a big deal for us to do this in order to safeguard our health and safeguard those that we claim we love. So I think it's very important that we send this message to all of our African American brothers and sisters.
Absolutely. Dr. Cadet, it's certainly been a pleasure having you tonight. And I certainly hope that we can come back and do this again. Actually, I would love to do a series with you, a weekly series. We can talk about these things and address them. So we can talk about that as well. But it's certainly been a pleasure. If our guests, and we have a ton of them here, and I'm so happy that they're here, if our guests wanted to, let me ask the question, and maybe I should ask the question first. If our guest wanted to contact you for general information or things of that nature, is there an address or a way they can contact you? Or would you prefer that they look on the social media sites and just follow your posted information?
I mean, you have my email and my personal email, and I can actually send you my work email. You have my personal email, but I can send you my work email, and then feel free to distribute my work email to your audience. And if they want to contact me to talk, I'd be very, very happy to discuss this with anyone. I think it's very important that as physicians, scientists, that we actually try to take care of our people as much as we can, just like you're doing. I think this is a great service that you're rendering to the Black community.
Well, thank you so very much. That's certainly our intent, and we do want to take care of our own. So guys, listen, I appreciate all of the guests being here. Dr. Cadet, our hearts are going up for you and thumbs are going up for you, and we certainly appreciate them. And we do really appreciate you being here. Again, audience, I am Melvin Casey Lars, your host, and we've had with us tonight Dr. Jean-Claude Cadet. Dr. Cadet is, as you guys know and heard, that he's very well versed, and I know you guys learned a lot because I saw the thumbs going up and I saw the hearts going up. So feel free to come back and join us again. So Dr. Cadet, we want you to hold on once the show finish. We can finish up a piece of our conversation and we're going to move forward. But guys, it's been great. We thank you very much. Please return next week to join us again. We'll look for our postings as to who our guests will be on next week. We like to keep you waiting. So we want you guys to have a great and blessed day.
Thank you very much. Thank you. Goodbye.